glucose is a charged, huge molecule, so it's very difficult for glucose to get into cells. That's why we need this huge glucose transporter to be operational. Otherwise, we're going to have a rise in our sugars in the bloodstream. So where does the sugar come from? Is it magic? No, it's not magic. We have a liver that does, more than 500 functions, and one of those functions is to break down glycogen. One of those functions is to break down lipids, right? Does it break down proteins? Yeah, it's going to break down proteins a little bit as well, right? So that's kind of what our liver does in our starvation state, right? When we are starving and we need to raise our sugar, right, because we don't have a meal being stuffed in our face, then we need to start breaking down stuff, right, to get energy for cellular processes. Okay, but what happens when you eat in the first place, right? When you eat, that's really where insulin is all over this, right? It's all about, it's like, oh, look at all this incoming stuff. They're going to start filing it away. They're going to get organizing. They're going to get super happy. They're going to start organizing everything, right? Was it Maria Kondo who wants to organize everything, right? So you got carbs, lipids, and proteins that get intake from your GI tract. And we're going to store those away as triglycerides, right? With insulin's help, you're going to use some of it for energy immediately. And then in the muscles, we're going to store it away as glycogen, right? And that will be storage for later for when we need glucose stores. We'll do that in the liver as well. We're going to get that stored away as glycogen, but also we're going to store away extra amino acids that we don't need. So it's like, oh, they don't need this forever for right now. Let's just go ahead and start breaking it down immediately. All right, so you're going to get an amino acid pool first of all, but whatever excess amino acids you have from your protein breakdown, you're going to start packaging that away as urea, right? And that is a waste product. And we talked about that in detail when we talked about kidneys and liver, right? In liver disease, this process gets broken down, right? Just halfway through, it gets broken down. So then the ammonia starts building up with amino acid excess, right? So in kidney disease, you just can't get rid of urea. It's like it just builds up with excess protein intake. Okay, and then so that's insulin. Insulin's all at work when you're eating. The first 2 to 4 hours of eating, you're storing everything away for when you have to, when you're not going to have food in the future. So what's happening over there? That's where you're going to start breaking down those glucose stores, right? I got glycogen in my muscles. I have glycogen in my liver. It's ready to go. It's my storage, my quick storage to be broken down immediately and cleaved in half, or however many halves it has to make it, down to a glucose molecule, right? And then I get that glucose in circulation, and now my cells can utilize that, right? And use that glucose immediately. And our brains are divas, just like our kidneys are divas. Our brains are, what's higher than a diva, like on a scale 1 to 10, right? So they're a queen, right? So they have to be, that's what they want. That's all they're going to accept, right? And they might take a little side of ketones, but they are not going to take what other cells take, like amino acids, for instance, right? Amino acids have a lot of things that can be broken down into energy and ATP, but the brain is not going to be for that. It's like, no, I'm not going to take that. I only take glucose. And I only take ketones. So we talked about the glucose. Where do ketones come from? Ketones are coming from the adipose, right? We stored away triglycerides up top. Now we have those ready to go in case our glycogen stores are gone in the future, right? For our brain. So our liver is going to break down those lipids, those triglycerides, into ketones. Those ketones can be used by our cells, but that's really what our brain likes to use, right? Our brain loves ketones and just straight up glucose. That's just two things that it's going to operate off of, right? And then what else can be broken down? That is our proteins, right? We can break down proteins for amino acids that can be then broken down by our cells, right? That's another source that our cells can utilize. Those amino acid parts can be utilized in the whole glycolysis cell respiration process to make ATP, okay? And if we don't use it there, then we're going to break it down into urea as waste, right? So what caused the breakdown of glycogen, lipids, and proteins? Those were the hormones we just talked about, right? So glycogen is broken down by by all of those 4 hormones, right? So glucagon, epinephrine, growth hormone, and cortisol. Do they do glycogenolysis? That's a yes, 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 right? Do they break down lipids? That's a yes as well, right? Yes, 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 yes. Do they break down proteins? That's only one of these breaks down, and that is what? cortisol, right? Cortisol is the only one that starts to break down proteins, therefore we get all those nasty side effects from it, right? And it's good that we have that as a backup, right? Where that is our backup to raise our sugar, if just in case. Okay, so adipose, right? America has a lot of adipose, so we do have the ability to use that as energy, and our amino acids we can use eventually, you know. But proteins are important. What proteins are important? Well, there's hemoglobin, there's collagen that kind of holds things together. There's all kinds of processes, muscles and such. Right? That's why we have a lot of muscle breakdown in the ICU. Why it's important to make sure we're not letting our patients waste away in the bed by mobilizing. And one of the reasons because they're getting steroids, right? We're giving them steroids in the ICU, and that's already working against them. Okay, so we got glycogenolysis, lipolysis, and proteolysis. All three of these things are going on to raise our sugar. Okay, so insulin is our only hypoglycemic hormone, right? It's going to reduce everything, right? It's going to stop all those breaking down processes, and it's going to uptake free fatty acids. That's going to make you fatter, unfortunately. So that's one of the side effects of insulin therapy. Okay, comes from the beta cells. We talked about the different locations of all these places. We talked about epinephrine and norepinephrine come from where? Not the adrenal cortex, but the adrenal medulla, right? The cortex was your glucocorticoids, all right? And medulla was that nougat center where norepinephrine and epi get released from. Okay, so there's a circadian rhythm to cortisol. So when we test for cortisol, we test in the morning. That's when it's highest, right? 6 in the morning or so. What else? So low blood sugar is kind of what stimulates this whole process here, right? When sugar is low, then the sugar is going to get high, right? That's the effect of these hyperglycemic hormones. Okay, so we talk about type 1 pathophys and how type 1 diabetes occurs is how type 2 occurs, right? So type 1 was an insulin what? What insulin was in what amount? Type 1 is insulin deficiency. There's no insulin circulating. Whereas in type 2, you got plenty of insulin. Insulin's for days, right? Until your pancreas is like, you know what? You don't care about me. I've been giving you signals the whole time. It's time for us to break up, and I'm just going to involute and apoptose, right? So that can happen with type 2 diabetes. And then that's why they say sometimes a type 2 diabetic becomes a type 1 diabetic, right? It's because their actual beta cells get exhausted, right? They get exhausted with the relationship. So we have insulin resistance that develops. And why do you get insulin resistance? Why do your cells no longer respond to those glucose transporters, right? Usually insulin comes in, binds the receptor, and the glucose transporter comes to the surface and allows glucose in. But for some reason, we have become resistant to this process, right? Receptors, not so much, it's more on the internal processes here. And what's going on is our obese clientele, they release what are called adipokines. And we talked about these in hematology, all the different cytokines and inflammatory mediators get released in a inflammation. But one of those things is from the adipose cells themselves. Right? Those adipose cells release these adipokines, and those adipokines are disrupting this process, making our cells resistant to this process here, to this insulin is attaching, it's doing its thing, but for some reason the glucose transporter is not making its way to the cell surface to get in the glucose because of these adipokines, right? So these adipokines are released during inflammation. So if someone is chronically inflamed, right, that can do it. But also there's the adipokines from the adipose tissue itself, right? And that's going to cause impaired glucose transporters, and that leads to our hyperglycemia. And then the adipokines themselves, they're going to take all the insulin from the other cells, right? So this cell might want it, right? They say, hey, do I get some insulin too? And the adipose is like, no, that belongs to me. I have more. There's more of me now. I need all this insulin. I am the one. Me. Choose me, right? So they kind of steal all the insulin from this other cells, and then your pancreas secretes out more beta cell activity, more insulin gets released, and that's how you have this insulin deficiency that eventually occurs, right? Or I should say deficiency, they get the insulin exhaustion that will occur, okay? And then this free fatty acids also impair our ability of our beta cells of the pancreas to sense that someone is hyperglycemic. So insulin's like doesn't have any off switch. Like, is that enough? And then doesn't hear anything on their side. So it starts to secrete insulin. It's like, is that enough? There's no way to tell. So then you get this hyperglycemic state, which has its own complications. But one of the immediate complications is that hyperglycemia is directly toxic to the beta cells. That's not helpful, right? You get glucotoxic because our sugar being so high impairs the beta cell function to begin with, right? So it doesn't let it sense what the sugar is. It impairs the insulin, and also then we get these adipose tissue secreting all these adipokines that are disrupting cellular function as well. So that's leading to a lot of situation, right? So a lot of sequelae, a lot of problems, right? So obesity, lifestyle, metabolic syndrome with increased abdominal fat puts you at high risk for type 2 diabetes. Right? What else can put you at risk for type 2 diabetes? Your beta cells just dying off with age can do it. There are some genetic reasons. If your first degree relative, your brother or your dad or so have diabetes, you're high risk for getting diabetes yourself. And then meds can do it because meds like glucocorticoids are constantly causing hyperglycemia, and we said hyperglycemia was toxic to the beta cells, right? So eventually the beta cells can't keep up and they just get exhausted. They're like, no more. I can't do this anymore. They're going to die off. And now you have a absolute insulin deficiency. You've gone from type 2 to type 1. Does it happen like within 6 months? No. This happens over 10 years, 15 years, 20 years of not properly managed diabetes. All right, so we want to avoid this glucotoxicity just on our white blood cells in the hospital setting, but we also want to avoid the ultimate destruction of our pancreas. Because diabetes is not just high sugar and that's it. It's going to damage our cells further, right? Which cells? Damage the vasculature, damage the nerve system, damage our eyes, which is kind of the nerves and vascular system also, damage our kidneys, which is more vascular, damage our heart and our brain for strokes. So it has a lot of consequences if we don't get the sugar under control. So what are the symptoms of too much sugar? Okay, so we got polyuria, polydipsia. Polyphagia kind of makes sense. My cells, they weren't getting the glucose, right? Those glucose transporters were not getting the glucose they needed because the adipokines were inhibiting it. The hyperglycemia there's plenty of sugar in the vascular system, but it's not getting to the cells. So the cell's like, what the heck? Where's my sugar at? So they're going to send off little signals of their own, which makes you hungry to eat a lot, which is the polyphagia symptom, right? But talking about polyuria. So polyuria is when you have this spillage of glucose into your urinary system, right? Usually glucose comes through the glomerulus, it travels right through, and you are going to reabsorb it via these little sodium glucose-like transporters in the kidneys, right? You have these in the gut, right? So if you eat too much sugar, not all the sugar is going to go into your bloodstream. Some of the sugar will get pooped out, right? So it's basically based on the transport maximum of your little transporters. If you think of this little transporter right here, you can only get so much glucose back into the bloodstream, right? The rest of the glucose is going to start spilling into the urine. And glucose is highly osmotically active, right? It's second place to what? What's the most osmotic, or I guess the most osmotically is albumin. But what's just after albumin? That has a huge oncotic pull. Sodium, right? So you got sodium, glucose, BUN, alcohol. These things are really going to be osmotically active when they're inside the bloodstream. Calcium too. Okay, so if all this glucose is spilling over, then the water is just going to follow it, and now you have polyuria. Right, it's all going to spill into the urine. So you get water being pulled into the tubules because we get our transporters have been maximized, right? And you can see you can measure this on the urine dipstick. Usually your transporters can handle about 180 grams, right? That's getting thrown through those nephrons. But once you start going higher than that, your sugar's like 200, 300, 400, 500, you're going to start getting a UA that's going to show glucose on the urine dipstick, right? So usually if you see like a 1+, that means that your sugar is about 250. And if you got 2+ on the dipstick, you're about 500. If you're 1,000, it's 3+, right? That's an approximate amount of spillage of glucose into the urine, right? Because your transporters are really good at absorbing 100% of the glucose until you get too high, okay? So only up to a certain point will you have a transport maximum. And after that, that's when you're going to spill into the urine and you're going to pull water, just like sodium does, and you get fluid loss and you get dehydrated. And dehydration can lead to low blood pressure, but this also is going to trigger our SNS to fire off, right? So you get SNS symptoms when you're dehydrated. Or do you get diaphoretic? Maybe initially, but usually dehydration, you're losing water, and you're not going to have enough water for diaphoresis. These guys usually, dehydration symptoms. They got sunken fontanelles. They have, tenting of the skin. They got dry mucous membranes, and they have tachycardia, tachypnea, which we're used to for an SNS response, right? And the other thing that causes when you get dehydrated, and one other thing that gets released is ADH, right? So here's our ADH story. So ADH gets released when you have hyperosmolarity, which is a fancy way of saying dehydrated, right? Or increased concentration. So the concentration of my serum gets higher, specific gravity, osmolarity, osmolality, however you want to spell it. If the concentration is high, ADH gets released, right? Maybe ADH has 5 different names, right? It's in witness protection. We have ADH, we have DDAVP, we have arginine vasopressin, you have arginine. There's all kinds of different names for it. The 2 common ones are vasopressin and antidiuretic hormone. So if I have really, really concentrated serum, I want to take the water that's getting lost and put it back in the bloodstream, right? And that will fix my hyperosmolarity. And that's exactly what it does, right? Vasopressin or ADH goes to the V2 receptors on the tubules, right? That's how you know the V2 over there. And they're going to tell the kidneys to reabsorb water, right? And that water is going to go, yes, it's going to increase our blood pressure, which is good. That's good for when we give vasopressin as a vasopressor, right? And that's going to increase my blood pressure. That's going to restore the concentration, right? And therefore, hopefully, we're going to keep that balance until our concentration is where it should be. And where should our concentration be? What should our serum osmolarity be? Should be about 280, 300, right? The normal serum osm. So if it's 280, 300, that's perfect. If the osmolarity starts getting more than 300, less than 280, would ADH get released?
I think it's too dilute.
So when it's getting more than 300, then ADH is going to start firing off. Increased concentration, greater than 300 serum osm, that's ADH going to start firing off, and it's going to start bringing that number down by diluting it down here, right? And how does it dilute it? Well, it's going to, as the water is going through here, right? The glucose is pulling the water, but it's going to like, I'm free, I'm going to pull, all the water is going to, it's going out. And then what does ADH do? It's like, not today. It's going to come in and give it a nice warm hug, right? It's going to pull all that water back into the bloodstream, right? All that water is going to go right back into the bloodstream. And how does it do that? It opens up little channels so that it's like, here, come, divert the water this way. But really what it's doing is grabbing urea, right? So urea is a waste product, but the other benefit of it is that it's osmotically active. We mentioned sodium, yes, albumin, but sodium, glucose, and BUN are osmotically active. So we take all the BUN and put it back to the bloodstream, then the water is going to follow, okay? And that will restore our blood volume, okay? So we get polyuria as a symptom. We get dehydrated, increased osmolarity, specific gravity, because we're losing all that water. And we're going to, our cells are starving, and we're going to keep secreting hormones to raise our sugars. So they're thirsty, yeah, but we got to fix the underlying problem, which is, kind of figuring out what's going on, right? Usually giving insulin is going to be one of the answers, right, to get that sugar under control. Okay, so the other piece to this was osmoreceptors. That's what kind of technically releases our vasopressin. So vasopressin gets released, it gets stimulated in the hypothalamus, where ADH comes from, and they have little cells here which change the release of ADH based on whether they are swollen or whether they're dehydrated, right? And when do you think they're going to release ADH? When they're swollen or dehydrated? When they are crenated or not crenated? Crenated being dehydrated. When should they do it? Because they're going to swell and not swell. They're going to swell and turn into raisins. When they start turning into raisins, right, when all their water is being drawn out of them, they're going to then be in this state right here, right? they're going to start, say, whoa, whoa, why, where's all the water going? We need more water balance, right? And they're going to they're going to start releasing ADH, right? That's what they have, little receptors, just like you have baroreceptors and O2 ketone receptors. You have osmoreceptors that are detecting the change in our cells, right? So sorry, I kind of mislabeled this, but this is a big cell over here. On the right over here, we got a nice big beefy cell there in dark blue, and then you see the cell shrunk, right? So that shrunk, and you're hyperosmolar, and that's going to cause it's like, whoa, shoot, what's going on? And that's attached to nerve endings, right? And those nerve endings are attached to the hypothalamus, and the hypothalamus will then release ADH in response. Okay, what else releases ADH? We got angiotensin 2, right? Stimulates ADH release. SNS stimulates ADH release, and SNS actually stimulates the RAS system, which releases angiotensin 2. So all three of these guys are going haywire whenever you have an SNS response, right? And it makes sense because those three guys are going to cause, somewhat indirectly, angiotensin 2 will stimulate aldosterone. Aldosterone will restore blood volume. ADH will restore blood volume, but all three of those guys, angiotensin 2, ADH, and the SNS epi-norepi will cause vasopressin, or pressing of the vasos, or vasoconstriction. Okay, so that's exactly what goes on also with ADH. It has the ADH function, it has the vasopressin function. Okay, and that will restore our blood pressure, hopefully, by vasoconstricting to reroute blood, and also stimulate our kidneys to reabsorb water. Okay, and of course this makes you thirsty. So those osmoreceptors not only shrink, right? They shrink, and it's going to tell our body to hold on to water, don't get any, let more water go. But it's also going to tell our brain, or tell the human, that you are thirsty. Get water, drink water, please. Okay, so that's the idea behind this. So you see the serum osmolarity is elevated there. Those cells shrunk. Okay. And then that's going to stimulate our hypothalamus, which is ADH. You see some vasoconstriction happening. You see our kidneys restoring water, and that's going to make our cells swell back up and stop the release of ADH. So what are our symptoms of diabetes? So symptoms of diabetes, we talked about the 3 Ps. Okay, so polyuria and polydipsia. They have incredible thirst because of ADH. They also have polyuria because the glucose is pulling all the water into the nephron, right? And hopefully, where the SNS will fire off because you're dehydrated. Also, because you're dehydrated, ADH will fire off and restore some water and blood volume. You get your SNS symptoms, tachycardia, tachypnea, and such. Will you get diaphoresis? Not really, because you're dehydrated, right? It depends on how dehydrated you are, but definitely you're going to be leaning towards not getting sweaty. Okay, if you're type 1 diabetic, so the symptoms for both type 1 and type 2 are the 3 Ps. You're going to have that for both, right? You have 3 Ps for both: polyuria, polydipsia, and polyphagia. Polyuria, polydipsia, polyphagia for both. And what else would you get? Well, type 1 diabetics, they're going to be thin, right? We know our type 2 diabetics are the obese variety, because it's usually what's going on is they have the adipokines disrupting the normal function of their pancreas, and that's why they're hyperglycemic. But your type 1 diabetics are thin despite eating. That's a classic presentation where they're always hungry all the time, right? And why are they thin? Because they're going to be breaking down lipids and breaking down proteins to raise the blood sugar, and because the cells are not responding to insulin. Why they're not responding to insulin? Because the insulin's not there, right? The beta cells are not secreting insulin at all. They are deficient beta cell destruction. So there's no insulin. The cell's like, whoa, where's my, I need sugar. It's going to release all these signals saying I'm hungry, I got polyphagia, and the person's going to keep eating and keep eating and keep eating, but they're going to keep losing weight because their body is also going to say, why are you not getting, we need to break down lipids, break down proteins. We need to, what's going on? We're in a starvation state right now, right? So that's why these guys are thin despite eating. All right, no glucose is entering the cell. And we then get all these hyperglycemic hormones that are causing proteolysis and lipolysis and causing them to be fatigued, weak with weight loss. So that's and of course the hunger, as we mentioned, that's the thin despite eating. And these guys present with DKA. HS is literally impossible in type 1 diabetes. So these guys present with DKA. So sometimes you look at textbooks, they'll kind of shuffle these things together and it looks a little confusing. It's like, oh, does a type 1 diabetic always have DKA symptoms? No, they present with the complications, right? the complication of type 1 diabetes being DK. And we'll talk about DK symptoms, but it's usually, abdominal pain. They got the ketones, they got the fruity breath and such, but we want to kind of clear out what is a diabetic symptom, like hyperglycemia, versus what are the DKA symptoms. Okay, and then our type 2 diabetics. So these guys are going to present, with complications too, right? They're going to, are they going to present because they're thirsty all the time? Are they because they're, because they're eating all the time? Not really. That's not really what they're going to be their priority. They're usually going to complain of something impairing their normal function. They got blurry vision, for instance, right? They have blurry vision because the type 2 diabetics can't, all this hyperglycemia, the actual cells in the cataracts in the lens can't digest the glucose completely, and it actually builds up and it osmotically pulls water into the lens of the eye, and they get this blurry vision that occurs. So they'll complain of blurry vision, which is a complication of type 2 diabetes. And they get infection. Why do you get infection? What do you need for to fight off an infection? You need effective white blood cells. And are white blood cells effective with a sugar over 200? No, especially if it's prolonged, right? And just in the hospital setting, if your sugar's over 200 for 2 days, 3 days, you're not going to get better compared to someone who had a sugar that was under 200. So these guys are going to present with infections. Vulvovaginal candidiasis being a common one in women. They present with the chronic UTIs, chronic fungal infections, right? And then we have neuropathies it's like, I'm always numb all the time. It's like, well, let's check your diabetes labs, right? And which lab is that usually? Use your A1C. That tells you the last 3 months of activity, right? So the A1C is greater than 6.5%, you have diabetes. Congratulations. There's no other way to say it, right? We got to get your sugar under control so that you don't have long-lasting complications, that your neuropathy doesn't get worse. Okay, these guys also get non-healing wounds for the same reason of low white blood cell function, right? Because white blood cells function at a sugar under 200. So we want our white blood cells functional, and if they're not functional because their sugar is too high, we're going to have the candidiasis. We're going to have non-healing wounds. Okay. And there's many other type 2 diabetes complications, from hypertension to kidney disease to heart disease to strokes and such, right? It's like, I'm perfectly healthy. It's like, when's the last you had a doctor? About 15 years ago. It's like, well, that might be, you might have we have diabetes, you got hypertension because of your diabetes, you have chronic kidney disease because of your hypertension and your diabetes, so it all interrelates, okay? So when we look at labs, you're gonna also see some glucose in the urine. You're going to see albumin in the urine as well, because you're going to start destroying technically the podocytes of the glomerulus. Those little cells right there, just like the lens of the eye, can't digest that extra step to get rid of the glucose small molecules, which cause the infiltration of water and swelling of the lens. It also swells the podocytes of the glomerulus and causes them to just be dysfunctional, break apart, and you get protein that will spill in the urine, and you get chronic kidney disease. Okay, so type 1 diabetes, very common in childhood, but type 2 diabetes is getting closer to childhood, right? So these guys, who's obese, who's not obese, our patients that are type 1 diabetic are not obese. They are usually thin despite eating because their body is constantly breaking down a lot of things. Are the ones that are obese also doing it? Yes, but it's not going to be as noticeable because they're obese. Right? So there's usually an autoimmune reason for type 1 diabetes. Right? Genetics is very, very high risk factor for type 1 diabetes. Type 2 diabetes, yes, you can, like your brother or your father has it, if your sister or mother has it. Okay. What's the treatment for both? The treatment is insulin for both. Usually the A1C greater than 9% is when you're going to start someone with type 2 diabetes. You're automatically saying, your sugar is way too high, we got to get your sugar under control. We're going to start you on insulin therapy. Otherwise, they're both going to be on oral agents. Okay, it usually goes vice versa. Usually you start definitely type 1 diabetics need insulin because they're deficient in insulin, right? And then if the sugar is still super high, we'll add some oral agents into the mix. All right, the complications are the same for both. All right, they get these macrovascular complications. We talk about ASCVD, which leads to coronary artery disease and leads to stroke as well, leads to peripheral arterial disease, it leads to erectile dysfunction. All these symptoms are all interrelated, right? Once you get CKD, now you have hypertension, and the ASCVD causes hypertension, the diabetes causes ASCVD, and the diabetes causes hypertension, the CKD. So it's all going to be interrelated and can cause an exponential increase in complications. right? We get nephropathies, we get gastroparesis, erectile dysfunction again because our nerves are breaking down and our vascular system is breaking down. It's not doing what it should. Okay, so we got resistance versus deficiency. Which one is type 1 diabetes? Where we have a decreased insulin because we are, decreased insulin because we are having yes, exhaustion, but we're having a absence of insulin production because our beta cells were attacked, right? Can you get exhaustion in type 2 diabetes? Yes, but our receptors are not responding to insulin because we have little adipokines that are disrupting it, right? And our cells are sending off hunger signals telling us what we need to get more sugar, and then the sugar goes up and we get more complications because the sugar keeps going up and up and up. Okay, so that's the idea, and the goal is to try to fix this as early as possible. Otherwise, you're at risk for diabetes taking hold at a younger age and leading to more complications, like we mentioned, with diabetes, hypertension, and the like.
All right, what do we got?
Just came in. Heart attack. 5'9", 300 pounds, 32 years old.
How the hell does that happen?
Can I get could be developing diabetes. Yeah, so exchange. Oh, yeah.
You're graduating! Watch TV. You wouldn't have to leave.
You can't do this.
Yes, can I get a...
Yeah, no, deep dish.
You have to make a change. Good job, Jen. You got an A+.
Here are your fries, sweetie.
I still can't believe you give this child french fries.
I know, but it's the only thing that'll make him stop.